I want to introduce again Stan Foster, who I guess needs no introduction. From the EIS class of 1962, a veteran of the Smallpox Eradication campaign in both Nigeria and Bangladesh, and currently the professor of global health at Emory University's Rollins School of Public Health. Stan?
Thank you all for coming. This picture, I was told by Dave Sensor, is a fraud. The firehouse was deleted by the person in visual aids. But anyway, this is how CDC looked when we were here for training 40 years ago. Just a brief history. I'm sure this was covered yesterday. CDC's roots were malaria control activities in war-affected areas created during World War II to protect military bases and related areas of the southeast from malaria. In 1945, the mission was expanded, maybe because there was no longer any malaria, and renamed the Communicable Disease Center by Surgeon General Joseph Mountain. The CDC mission, and it's important that we remember that mission, is to support the states through partnership, manpower development, and research. The EIS was started by Alex Langmuir in 1951, and during the 50s and 60s, public health advisors were assigned to states to support immunization and STD programs. Alex Langmuir, the teacher, bringing Farr, Snow, Goldberg, and Frost to life in the classroom. Langmuir, the visionary who believed anyone bright enough to be in EIS could, with a month's training, effectively respond to any emergency in the world before the sun is down or you are not going. Langmuir, the caring mentor who encouraged his officers and sent them back till they got it right. Langmuir, the editor who returned draft 10 with more red marks than draft 1, and Langmuir, the father who loved and cared about his EIS officers and their families. A few years ago, I went through all the Epi-AIDS from the beginning. There were some Epi-1s with no Epi-2s. I don't know how that happened, but and there were really only 3 international activities in CDC's early history. First was a flood in Winnipeg, an obscure febrile illness in Santa Cruz, Bolivia, and a smallpox outbreak in East Pakistan, now Bangladesh. And Langmuir and 10 EIS officers documented 14,000 smallpox cases, found smallpox vaccine protective, and identified one and only one important risk factor: non-vaccination. On the other hand, in the 1960s, measles was the major killer of African children, an estimated 20% case fatality rate. Edmonston V vaccine had been developed but had to be given with gamma globulin. It was unlicensed. And there happened by chance a visit by 4 ministers of health from West Africa. And the Minister of Health from Upper Volta, seeing its political potential and medical potential, volunteered his countries for studies. Harry Meyer from NIH carried out one study in 1961 which proved to be very effective and safe, and then mass campaigns followed, I think that's 62, 63, and 700,000 children in Upper Volta. The measles incidence fell sharply, and it was a medical and political success. Because of the success, the OCCGE ministers requested USAID to expand training in 6 countries. $1.5 million was allocated, and USAID turned to CDC for technical assistance. EI officers, including Altman, Lane, and Henderson, were sent to the field, and USAID expanded the programs to 4 OSEAC countries. Their epidemiologic thinking was somewhat strange. We vaccinate 1/4 of people the first year, 1/4 the second, 1/4 the third, and 1/4 the fourth, and we're done. The logistics were horrible. There were big trucks. The refrigerators, the kerosene refrigerators were over the gas tanks. The trucks blew up. The electric jet injectors wouldn't work. And there's a wonderful cable by Larry Altman, who's now the science editor at the Times. He said, the trucks don't keep the vaccine cold. The reply he got from Washington was, park in shade. Altman replied to the State Department, send trees. USAID requested increased involvement. On the smallpox side, Don Millar was appointed Langmuir's assistant and given responsible for smallpox surveillance. He tracked 5 importations into the UK. He investigated a large outbreak in Indonesia and headed up the first smallpox surveillance unit. And then he traveled to Brazil. A smallpox case traveled through New York City, and 1,000 people were put under surveillance. No cases developed. And then there's a famous rash case in Washington, D.C. that was diagnosed as smallpox, which was in fact chickenpox. And there was a congressional hearing, and Dave Sensor completely diffused the anger by saying we made a mistake. D.A. Henderson was sent to WHO Geneva to head the global program, and Don Millar was head. At the same time, there were a lot of research activities. First, giving diphtheria vaccine with a jet injector, testing the jet injector gun with smallpox being at the prison and in Jamaica. Aaron Ismark of the U.S. Army developed the foot-powered jet injector. It was tested successfully in Tonga and Brazil. And Tom Mack, who was here, carried out some superb epidemiologic studies of smallpox in Pakistan. Another interesting thing was at that time, India was doing more vaccinations, but the population had lots and lots of smallpox. So Henry Gelfand went out and did an assessment, and he found the vaccinators were vaccinating the school kids every month, so they get high numbers, but coverage was very low. And then on the domestic front, Mike Lane and John Neff began to document the cost of routine vaccination here in the States. As far as smallpox eradication goes, the Soviet Union first entered a resolution to this WHO Assembly. It provided 1 million doses of vaccine. And in preparation for the U.S. delegation to the World Health Assembly, Ben Blood, James Watt, and D.A. Henderson engineered a presidential decision that the U.S. would support the global eradication of smallpox. I was told by D.A. the other day that even the head of whatever it was called, Health and Human Services, didn't know about it. But anyway, it got on the agenda. It made the press. And then a few years later, or a little bit later that year, the White House also announced the smallpox measles program. And it's interesting from a historical that this press release was written by Bill Moyers. Dave Sensor, I think he looks about the same today. CDC was a domestic health agency. He saw international health as a legitimate activity to protect the health of the American people. He supported the assignment of CDC to the measles activity. He proposed smallpox eradication in the Americas in 1970. And in July 1965, received a call from Dr. Curtis at AID, who proposed a West African measles eradication program. Sensor told him that measles eradication was technically impossible and proposed that measles control and smallpox eradication be combined. Curtis agreed. I don't think he recognized how much it was going to cost him. USAID objected to the inclusion of Ghana and Nigeria, which had a population at that time of 59 million, and CDC refused to go forward unless it was a regional program, and the program was almost canceled in the November of '65. Finally, the White House release and the approval. Back in '65, our best estimates of smallpox were 20 million cases and 3 million deaths. These are pictures, I believe, by Tom Mack, and it's important while we talk at the numbers that we remember that each of those smallpox cases represents an individual, a mother, a child. From a policy point of view, and it's not to look at this, is you have on the left this sort of the measles chain, you have CDC with the smallpox chain, you got the White House, and you got WHO. And from a policy perspective, leaders in the program were able to pull all these things together.